Update, a clinical continuum in psychiatry. The American College of Psychiatrists presents Update, a series of educational audio cassette programs designed to assist you in your efforts to maintain clinical competence and to broaden your understanding in specialized practice. Today's program is a panel discussion of recent advances in child psychiatry. And here is your moderator.
I am Paul L. Adams, M.D., Kempner Professor of Child Psychiatry at the University of Texas Medical Branch in Galveston.
And I'm Thomas F. Anders, M.D., Professor of Psychiatry and Human Behavior at Brown University and Bradley Hospital in Providence, Rhode Island.
I'm Frank T. Rafferty, Vice President of Medical Affairs of Healthcare International, which is an affiliate of the Brown Schools based in Austin, Texas.
Our task is to say some things about the developments within the field of child psychiatry that will be of some interest to practitioners. Child psychiatry in the past 10 or 15 years has adopted a growing focus on research, and I think that's important for any new medical specialty. The research that is being done, though, is not effete and unrelated to clinical problems, because the research has been inclined more and more toward disorders of biological development, disorders of learning, conduct disorders, which are probably the most important statistically of all the childhood conditions, and some work in the childhood psychoses, severe developmental disabilities. In general, the research in child psychiatry very sensibly has concerned itself with chronic and severe disorders. What advances have been made in the past decade or so, Frank, as you see it, in the treatment of juvenile delinquents, kids who are suffering from conduct disorders?
Well, you may remember that in a previous reincarnation, I was director of the Institute for Juvenile Research, and juvenile delinquency was one of our greatest fields of interest. And I must tell you that as a result of that, I never talk about delinquency in children anymore. The more research that we did on delinquency, the less we had any opportunity of connecting it with clinical syndromes or behavior. So that particularly when we got into doing anthropological research on delinquency and on the self-reported delinquency, when we found out that, of course, acts of delinquency are many, many more times prevalent than any reported of it, and the whole incidence of official adjudicated delinquency being that which comes from a juvenile court has absolutely no relevance to clinical conditions. So that turning it around now, what I do in our hospitals, for example, if somebody says, do you admit delinquents? Well, we admit mentally ill children who are seriously ill enough to be treated. Some of those mentally ill children may have committed delinquent acts, but we would not admit some youngster that had committed a delinquent act if he did not also have a diagnosis of mental illness. So that I'm very much more interested in talking about the diagnosis of mental illness, of which the conduct disorder, of course, is.
But what treatment is child psychiatry making available for kids with conduct disorder? What's new in the field? Or old, but very worthwhile?
Well, I'm not sure whether it's new or whether it's sort of catching up to us in a sense, but I think that much of it resolves to the whole business we've talked about a lot about the establishment of a therapeutic alliance. And I think the major problem with our psychotherapy is that we define psychotherapy as requiring some kind of therapeutic alliance before it would be successful, and yet frequently we would go on month after month, year after year with youngsters who are obviously not establishing a therapeutic alliance and not do anything else. I think that what has happened is that many people involved in doing what was first thought of as residential treatment and now hospitalization of adolescents have found various kinds of ways to relate to youngsters in what's thought of as the peer group, the milieu, the structured treatment situations, which in fact, I don't know, I kind of think of it as an analog to what the orthopedist does when he puts a cast on a broken limb. You find a way of immobilizing the youngster's behavior in a highly structured social context. When you've done that, then that potentiates your psychotherapy and your pharmacological therapies a great deal, and allows you to have a reasonable shot at treatment in these very difficult conduct disorder kids.
And I've been impressed with the efficacy of behavior therapy with kids who are suffering from conduct disorders, and especially if they're in an institution, whether a mental hospital or a correctional facility. And I think that it could be said with a certain amount of accuracy and validity, and maybe some relevance to our general psychiatry colleagues, that whenever it's possible for a kid who has been engaged in delinquent behavior, has other earmarks of conduct disorder, the young person benefits still to a much higher degree from being directed toward the mental health or mental hospital facility than toward a correctional facility. Our recidivism rate and our overall treatment outcomes are still a cut above what can be accomplished in the correctional facilities.
I think the connection between that would lead us very much to Tom's work, which is the thing that we probably spend more time on than anything else in our treatment programs, is attachment behavior. And Tom, you...
Well, I was going to jump in the fray without that introduction because I'm struck, on the one hand, that conduct disorder, which is a diagnosis that we use, is probably a mixed bag, that within that diagnosis are multiple subtypes of conduct disorder. Perhaps some of them, at least in the follow-up studies, some of the children or adolescents who present as conduct disorders later get into drug abusive and alcohol abusive, addictive kinds of behaviors, and there's some suggestion that this rides with families, whether it's genetic or related to socioeconomic class or the culture of poverty or deprivation is not clear. But for some, that's an outcome rather than criminal behavior, whereas for others, criminal behavior is the outcome, or there's a combination. And again, within the conduct disorder category, there seems to be some evidence for some that depression is an underlying illness that needs to be treated, and when that depression is treated, at least from some work that Pujantik has reported, the conduct disordered symptoms improve. So one of the things we need to do is refine our diagnostic criteria. But what I was going to say, too, is that once you have an adolescent with a conduct disorder, it seems to me that in general the prognosis is pretty grim. These kids are tough to treat, and they require multimodal approaches and everything we've got, and then the likelihood of success is slim. So one of the things that's been exciting to me is, can you predict the conduct disorders earlier than adolescents? Can you predict pre-conduct disorders? And if so, can you treat at that level? And this brings me to some of the very exciting research that a developmental psychologist at the University of Minnesota by the name of Alan Srofe has been writing about and studying. Namely, we know now that infants can be classified at 1 year of age using a separation reunion paradigm, an experimental procedure where the mother and child come to a laboratory and undergo a series of separations and reunions, and strangers enter, and then blind raters look at a videotape and can classify at 1 year of age that relationship between the mother and the child as either a secure attachment relationship or an anxious attachment relationship. And within the anxious attachment relationship category, there's two subtypes, the resistant and the avoidant attachment relationships. And that's a stable categorization, so that if that's repeated 6 months later or 8 months later, the infants whose relationships with their caregiver has been categorized as secure or resistant or avoidant will continue to be categorized that way. But what's interesting to me is that Srofe has data in children of lower socioeconomic poverty culture in Minneapolis, Minnesota, backgrounds, that these children, when placed in a nursery school setting and examined when they're 4 years old and 5 years old in the preschool period, can be separated or distinguished on the basis of that earlier classification of relationship at 1 year of age. And what Srofe has reported is that those children who were classified as avoidantly attached, that is, when the mother came into the room when they were 1 year old, they didn't want to pay her any attention, and when she left the room, they didn't protest very much. And in some ways, they treated the stranger at 1 year of age much like the mother. They avoided contact. Those children, when they're 4 or 5 years of age, are the children who are the bullies in the classroom, and they beat up other kids, and they will lie, they will steal things, and they will be, from an interpersonal sense, socially isolated. And Schroff says that at that age, if it's a therapeutic classroom and the teacher is going to relate to the child in a way that is different than what the child has learned to expect from their home environment, the child over the course of a year may in fact change their interactions with peers and strangers. So possibly, I mean, this is still, I think, too speculative to be certain about, but possibly one might be able to predict conduct disorders. There's no longitudinal data out to that age group yet, at a preschool age, and then design an intervention that might have some...
If you know the nature of the attachment between the infant and the mother, or the caretaking adult, then the prediction can be made with some soundness. I think that's very interesting, and it's a little bit reminiscent of some of the maybe more theoretical conjecture that was done by Bowlby and by Mary Ainsworth earlier on, and Winnicott certainly, in their talk of the affectionless character as somebody who had been deprived of a kind of bonding to a caretaking figure in earliest infancy.
It shows some kind of a intergenerational transmission of a behavior pattern. We know in the child abuse field, for example, that it's much more likely that an infant who is battered by its mother has a mother who was battered herself as an infant, that this is a cross-generational type of behavior.
Certainly physical abuse, sexual abuse follow that pattern of transmission from one generation to another. And I guess the old saw is still fairly accurate, that we can thank our families both for giving us kind of selective exposure to a gene pool and for giving us an exposure to a system of values and norms and beliefs that are transmitted through the family. So both the psychogenic and the biogenic disorders certainly show a high familial incidence. Would you say that family group therapy and behavior therapy with this large group of conduct disordered children have been helpful and useful in some ways?
It's become almost the same thing. You know, it used to be virginity and motherhood and apple pie, and I think now we have to add family therapy. So that in most kinds of situations, if you don't add family therapy to your treatment plan, it probably won't be approved by either Champa's or the insurance company or whomever.
And they're not comprehensive enough.
Right. So that, yes, of course the answer is every child must be treated in his family. But I would like to add some of the other side of that, which is there are many children, of course, who have passed through family therapy. We get any number of failures. Previous very adequate family therapy. I suppose it must be at least once a month that somebody will call me from some distant city and say, "Frank, for God's sake, help me get this kid out of town. He's had 3 episodes of serious illness, and every time he gets into seriously ill, he goes into family therapy. And the family's getting an awful lot better, but the kid really is still very ill." And so I think that there are many youngsters who can profit from family therapy, but I think there are many youngsters who need family therapy and individual therapy, and I think that there are many youngsters who certainly ought to be in all varieties of individual attention to their illness, working with the family for future care and support is important after that, but that one should not believe that family therapy is any more of a panacea to illness than tricyclics or Thorazine.
Maybe ultimately we are somehow struggling to get to that point where we can have an armamentarium, a therapeutic armamentarium that's a little more multifaceted and multimodal than it has been heretofore, so that we can selectively utilize family group therapy, behavior therapy, individual psychotherapy of the more dynamic variety, pharmacotherapy, and with this enlarged armamentarium of therapeutic modalities, we might really be better able to serve young people with these difficult problems of conduct disorders.
Just to highlight that a bit, there's only 3,000 child psychiatrists in practice in the country today, and actually there's some 30,000 adult psychiatrists in practice, and there's about the same number, 25, 30,000 pediatricians in practice. And when we considered the notion that child psychiatrists might be tertiary care specialists, I wonder what you think about having the general psychiatrist treat more families, including the children of the families, perhaps being more involved in pharmacotherapy with children as they become more involved with pharmacotherapy of adults. How you see the psychiatrist, adult psychiatrist, getting involved at that level, or perhaps the pediatrician?
Well, I think the fact of the matter is that the general psychiatrist, and I really hope that the people that I have helped to train as general psychiatrists are generalists, truly generalists, and not just adult psychiatrists, because that's a very restricted and sometimes not even the most interesting part of the lifespan or the life cycle. If they are truly general psychiatrists and have the training of a generalist and have incorporated the developmental outlook and approach in their work, it seems to me that the general psychiatrists do very well with children and their families. Would you quarrel with that?
Well, I don't know whether to quarrel with it or not, but I do have some sense that there seems to be some kind of intrinsic barrier to a general psychiatrist seeing an adult, let's say a depressed woman, and being concerned about that woman's children, and I don't know why. I think there's some kind of barrier there. I don't think it's just a question of who trained them or whether they had enough developmental training in their residency or not, but I think there's some kind of barrier having to do with the daily work of a adult psychiatrist with his depressed parent, paying attention to the children at the same time and being able to think to refer those children to a child psychiatrist. In my most paranoid moments, maybe, I sometimes wonder whether the other psychiatrist is aware of the fact that maybe the family can only support the payment for one patient and hesitates to add an increased financial burden to the family that would come from sending a child into even assessment for treatment.
Well, you certainly haven't seen anything that would suggest that when funds are short, they're devoted to adults and their care, have you?
Well, my paranoia is less than a lot of other child psychiatrists because I think it's a built-in fact of life that children will always come after adults, and I'm prepared to accept that. I think that's the way it is in nature. The adults have to survive to reproduce the species. The children can die off, and the adults can bring some more. So that I don't have any trouble with accepting that as a fact of life. But
I think there's adequate evidence from the work of, say, Myrna Weissman at Yale, that having a depressed parent is a high-risk situation for a child in that family. And if any of us, including adult psychiatrists, have any kind of a preventative approach to the practice of medicine, it's almost, well, maybe this is said too strongly. What I was going to say was it's almost tantamount to malpractice for an adult psychiatrist to be treating a depressed mother or father and not inquire about the well-being of that child, because the data so overwhelmingly favor poor parenting during that time of depression, and that having a lasting effect on the child's growth and development. So maybe there'll be lawsuits one of these days.
we know it's become a very trendy topic for the TV and for the newspapers about the child of the adult alcoholic.
Yes, yes.
Which seldom gets referred.
But they all have a major loss, and it's a loss really of the parental force in their lives.
Yes.
And I think that's an excellent thing when the general psychiatrist does remember to include the children and to realize that psychiatric services, though they must be directed primarily to the depressed or schizophrenic adult, must also be broad enough in their scope that they will include the children in the family, because those children really are put at great risk if they're not included.
Well, my reason for bringing it up was that I feel that the general psychiatrist is a more likely person to carry out that role than the pediatrician. and that the personalities, if you will, of general psychiatrists and child psychiatrists are more alike than different. And they're more alike than the child psychiatrist and the pediatrician, who are quite different in my experience, and I think should be different. Vive la différence. And I think that general psychiatrists would be better equipped to carry out these roles if we could overcome that barrier.
Well, the conduct disorders then are an important issue in the field of child psychiatry, and some new and different and some promising things are on the horizon there.
I think it's important to remember that a lot of the research that's going on in child psychiatry is clinical research and is very useful to practitioners in the community. For example, the group at Stanford, with which I was involved for many years, but primarily including Bill Dement and Mary Carskaden, have looked at sleepiness as something that affects adolescents particularly. It's common experience with one's own child, but also from one's practice, that children, before they are of adolescent age, never complain of sleepiness. Now, we'll get into a little bit later maybe that depressed children may, in fact, complain of sleepiness and may, in fact, take naps while they're preschoolers or school-aged. But by and large, non-depressed children will never say, "I'm tired," or take a nap. But we all know that the minute the child hits adolescence, they're hard to get out of bed in the morning. Saturday mornings they sleep in. They always complain of tiredness. In fact, Bill Dement did a survey in Stanford freshmen and found that 30% fell asleep during class, during the day. And it had nothing to do with the boring or excitement of the lecture. They were just overly tired. And this sleepiness phenomenon, we now know from data, is something that is both related to sleep restriction, sleep loss, sleep deprivation, which adolescents are prone to, but also endocrinologic changes associated with puberty. For example, if you look at sleepiness over Tanner staging, which is a way of examining the stage of puberty, there's a straight line correlation between the amount of sleepiness that the adolescent experiences and the Tanner stage that they have achieved in terms of their pubertal development. From a clinical perspective, there are some disorders of excessive sleepiness, diagnoses which we now make in adolescents, which we didn't do 5 years ago. Narcolepsy is a good example. Narcolepsy was thought to be a relatively rare disorder confined to adults, and 20 years ago, general psychiatrists thought narcolepsy was a variant of schizophrenia, and we used to have them on our inpatient services when I was training as a resident. Now, at least, we know from sleep research that narcolepsy is a disorder of REM sleep, that it involves REM sleep attacks occurring during wakefulness, and that it starts in adolescence. The adolescent, however, who feels sleepy or who feels the irresistible urge to fall asleep without the benefit of a sleep study, becomes hyperactive. They try to fight off sleep. So frequently they're diagnosed as an attention deficit disorder. Or sometimes they have micro-sleep attacks, which are unbeknownst to them or teachers. They fall asleep for brief periods, 10 seconds, 20 seconds, usually less than 30 seconds, and then wake up again. They don't know that they've missed something, but in fact they have, and so they end up not doing well in school, and so they often come to the child psychiatrist as a learning problem. The diagnosis is relatively easy to make. If you just ask the questions about feeling sleepy, the family history, and the concomitant signs about loss of muscle tone, called cataplexy, or sometimes vivid hypnagogic hallucinations. When they fall asleep, they just begin sleep by going into REM sleep, and they have these dreamlike experiences. So just knowing about it is sufficient to make the diagnosis, and one doesn't need a sleep lab. The other area where excessive sleepiness has been shown to occur in children is in what's been called the obstructive sleep apnea syndrome. In that syndrome, usually in childhood, due to hypertrophied tonsils and adenoids, when the children are asleep, they develop nasopharyngeal obstruction and they can't breathe. They develop a period of apnea and they wake up. And these repetitive wakenings, sometimes 100 to 200 times a night, leads to sleep loss. So they're really insomniac, but they don't know it, especially in the beginning, and then they feel sleepy in the daytime, and they fall asleep in class, or they fail to learn, or to fight sleepiness, they become hyperactive. Children do not tell people that they're sleepy, by and large, so one has to ask about it. And so I think that's another example of a sleep disorder which has been established in the laboratory, but now can be determined clinically. The pathognomonic sign of the obstructive sleep apnea is to ask the parent, does the child snore, and do they have an expiratory snore, not an inspiratory snore? Or you can put a little cassette recorder, an audio cassette recorder by the bedside, and you can hear these snores and stop breathing episodes. If the parent says yes, or you record them on the tape recorder, you have a diagnosis. And a tonsillectomy, a TNA, is curative. So those are two examples, I think, of helping children without sending them into long-term psychotherapy.
So the sleep disorders may be studied in the university setting, but the research has very practical benefits and effects for the general practitioner.
Update will continue on the second side of this cassette. We now continue with Update.
Just to keep our clinician friends happy, if the average child in the average family says, I'm tired and I want to go take a nap, should one be concerned that child is depressed?
Well, I think the answer to that is a developmental one. If the child is past puberty and says, I'm tired, I want to take a nap, we should look towards sleep loss. That is, they've been staying up too late studying or partying, and a sleep deprivation-like syndrome as the cause of that feeling tired and wanting to take a nap. If the child is prepubertal, we heard Elva Poznansky say today, and I'll quote her, it's almost pathognomonic of childhood depression if a pre-adolescent child in the middle of the day says, I'm tired, and goes in and takes a nap. Falling asleep during the daytime is very difficult for preschool children. Dr. Karskaden at Stanford has developed something that she calls the multiple sleep latency test. It's very simple. It measures how sleepy are you. Well, how do you know how sleepy you are unless when you say you're sleepy you can fall asleep? So what she does is 6 times during the diurnal day, she has someone try to fall asleep within 20 minutes. You go into a dark room, quiet, and you try to fall asleep. No child before puberty can fall asleep in the 20 minutes. They lie there in a darkened room, they try to fall asleep, but they can't fall asleep. According to Elva, if the child can fall asleep, then they're depressed. I support that notion.
I didn't learn to fall asleep the drop of a hat until I was in medical school and experienced sleep deprivation and just grabbed sleep whenever I could.
Well, adolescents, once puberty begins, can fall asleep during the daytime, during this multiple sleep latency test. And that's even if they've had 10 hours of sleep the night before. That, I think, disappears again when they reach adulthood. I think that there's a period when the hormonal changes of puberty are so active in affecting body changes and psychological that sleepiness becomes more apparent. And then as the hormonal changes have a chance to be adapted into the functioning individual, the sleepiness disappears again.
I would like to push you a little bit on that, Tom. Suppose this is a general physician and they have this child that is sleeping, age 10. Are we to believe then that this child, in fact, has a depressive illness? Suppose the parent says, there's nothing wrong in our family. There's been no loss. Nothing's happened. Our family's happy. We have a fine family life. I really can't accept, doctor, that this is a depressed child.
Well, I think what you're asking is, can you, on the basis of one clinical symptom, make a diagnosis? And I think, as we all know, you can't, but it certainly warrants an evaluation. The fact that the parent says the child is not depressed again, using Poznansky's data, would not be as important as what the child says. There's always in child psychiatry the discrepancy between the parental report and the child's report. They may view the same behavior differently. And in Poznansky's data, if the child says, I'm depressed, or I feel sad, or I'm unhappy, or I cry, or something along that line, then it's more likely that the child will be depressed with a depressive illness. And it will be more likely that that would be the child who would be taking the naps and be showing some of the biological symptoms of depression than if the parent says the child is not depressed. She makes the point that in conduct disorders, which you were talking about before, the reverse is true. The child is more likely to say, no, I don't steal, I don't lie, and the parent says the child has been reported to the police and the teacher, etc., and so that the parent's view in that syndrome seems more reliable as a predictor of psychopathology. But let me turn it around to you. I mean, in your hospital, or multiple hospitals where you have these children and adolescents for periods of time, how regularly do you assess the adequacy of their sleep? How adequate are your records of sleep behavior as indicators that the child is improving, that a depressed child is sleeping better, or that you're not missing narcolepsy or sleep apnea, hypersomnia, because you don't know whether the children snore or not at night? We in child psychiatry that are running hospital programs aren't incorporating these findings from the laboratory.
I think it's certainly become much more frequent in the last few years as we've started to use the tricyclics, as we've started to believe in the incidence of depression in children rather than thinking of the masked depression of the acting out child. I think that we have begun to ask about sleeping disorders and to have found them. I must admit, I don't know that we're finding much narcolepsy, but we certainly are finding very much the sleep disorders of the depressed adolescent.
So the depressed adolescent is the kind of psychopathological specimen that you see a good bit in addition to the conduct disorders among the hospitalized children and adolescents?
Well, I think the range of psychopathology in adolescence is very broad when you think of the fact of how many adolescents come in with post-head trauma syndromes, how many are in because of some mild early organic insult, or how many are in because of various kinds of learning disabilities. So there's a tremendous range, and to some extent it works to the issue I was talking about before of the referral patterns. I'm so often at the end of a very long referral pattern that I find it very difficult sometimes to relate to why this particular family, this particular doctor refers this particular youngster. There's plenty of them, but there are only so many who do get referred. It's a special culture.
Do you find, Frank, that the sleep patterns of adolescents who are depressed are much more typically problems of insomnia or problems of hypersomnia, as Tom has been describing? That
I think it's both. You see hypersomnia, and you see a lot of more disrupted sleep. Difficulty going to sleep is quite common, and waking during the night is common, and then hypersomnia.
How do you treat young people with depression, with a major depressive illness? How are they treated, aside from the milieu and an effort to try to help them to get remotivated, remoralized, and so on?
I think it depends where you are in the continuum of care. If you are a primary physician or even a primary psychiatrist, the first one to see the child, I think the treatment is definitely two-pronged. Pharmacotherapy is required at this stage, and the psychotherapy to support that. There was this wonderful article in the archives a couple of months ago about the clinical illusion, where the issue is not so much what causes an illness, but what keeps it maintained. And I think that is one of the issues, because there obviously are an awful lot of young people out there with relatively severe illnesses like depression who respond quite promptly to some care by the first doctor that sees them. And then the issue is, what about those youngsters who do not respond to the tricyclics? Or what about those where I see them in the tertiary situation who may respond very promptly to tricyclics, but they've been depressed so long that they're totally devoid in all the ego strengths that we think of required for a child to survive in society, and therefore you need to treat them for a long period of time in a very carefully structured situation in order for them to acquire those things which seem like simple social skills, but they're not. They're very complicated skills.
I've been very impressed that use of the tricyclic antidepressants with children and adolescents. I've found that the formula of computing a certain amount of tricyclic per kilo of body weight may be a good general guide, but if a kid does not get better on the tricyclic antidepressant, thank goodness we can send their blood to the laboratory and measure whether they are receiving a therapeutic dosage of the medication. It seems to me in children I've run into a lot more difficulties than with adult patients, that it's easier with adults to sort of bet on 150 to 200 milligrams a day of one of the major tricyclic antidepressants. But with adolescents and children, you may have to increase that considerably until you get them up to the therapeutic level. Is that coincide with your experience, Tom?
Well, yes, and I definitely think that the area of pediatric psychopharmacology is an area of its own right, that children metabolize drugs differently at different points in their development, and that needs to be taken into account when one is prescribing. And I agree with you that blood levels are much more important in children.
I suppose we should mention, just for the sake of mentioning, the dexamethasone suppressant test. Is anyone still using that in adolescent
sure. In academia, you have that luxury that you can use all these things, even if they are simply beneficial as screening devices. Do you use the
I do. I use it in two instances primarily. I use it as a screening measure. It doesn't determine what I will prescribe or the diagnosis, but if it's positive, if the child fails to suppress, then the response on medication frequently is to normalize that, and that's an indicator that therapy is being effective. So I use it in the treatment. And the other area that's very interesting is in its use with anorexia nervosa. Everybody who's starved has an abnormal dexamethasone suppression test, so that it doesn't mean that one is depressed and has anorexia nervosa.
Are they non-suppressors?
Yeah.
The anorexics?
In the starved condition, they are. The interesting thing is that when they regain their weight, a small subgroup do not normalize their dex tests. They continue to have abnormal suppression. And in our experience, their likelihood of relapse into a starved condition is greater. So there we use it, again, in some way, not to make the diagnosis, but in some way to determine a prognostic statement, that if it's not normalized, they may not be ready to go home from the hospital.
Well, that's comparable to the adult finding, then, in terms of just regular depression.
Yes, but not in anorexia nervosa. Yeah.
Mm-hmm.
And that may be the group that are anorectic and depressed, because clearly there is a subgroup in anorexia nervosa that also are depressed.
Well, I think Hilda Bruch and others always contended that the person with primary anorexia nervosa was suffering from an obsessive-compulsive disorder, in truth. But there were other young people who had anorexia nervosa who were basically depressed, so they were secondarily anorexic. Yes. They were suffering from depression or from schizophrenia or from some kind of hysterical condition.
I think the category of primary and secondary that Hilda Bruch established is a valid way to look at anorexia nervosa, but what I was talking about is primarily those children, young adolescents, whom she would call primary anorexia nervosa. The depression is not apparent, and only when you do this dexamethasone suppression test, which is going to be abnormal anyway in the starved state, but then remains abnormal, do you have a sense that there's an underlying depression or an associated depression in these children that's not apparent symptomatically. The kind of depression she was talking about was clinical depression, where the anorexia was secondary to the biological concomitant of depression, and that wasn't exactly what I was talking about. Mm-hmm. But I think, one could say that anorexia nervosa is on the increase, that it's assuming epidemic proportions.
With younger and younger...
With younger and younger children, which in some way is not bad, because the younger they are, when you get them to treat, the easier they are to treat and the better their prognosis is.
What is the treatment that you're more interested in giving them at the moment?
We've been using again, multimodality approach. It's very easy using behavioral modification techniques to get them to regain their weight now. you develop a program in which their privilege status in some meaningful way is hooked to their weight gain, and they will gain weight for you. The fight always comes when they approximate that point in their contract that they're about to get to a discharge weight, but they stay a few kilos, 1 or 2 kilos below that, so that they can fight and struggle with you about it. And that's where the therapy gets involved. But in a behavioral modification program, you do need that in order to get them to regain weight. At the same time, if you don't use an individual psychotherapy approach and develop a relationship with this child, as well as a family approach and develop an alliance with the family, you're doomed. And the younger they are, and the earlier it is in the course of the illness, the easier it is to develop these kinds of alliances and initiate treatment, in our experience. So we have an inpatient component within a discharge to an outpatient setting, and a multimodal approach. For those children, adolescents who have the abnormal DST, we add an antidepressant. So we'll use everything. And I think we've been successful. We haven't, luckily, seen that 10% mortality figure, which continues to pop up, making it a very dangerous illness. But again, in the older, longer-standing anorectics that you see that.
Well, it would be difficult, certainly, for anybody who's getting 100, 150 milligrams of imipramine a day not to have some change in appetite, because I think in general, patients who are taking the tricyclics experience an upsurge in their appetite and food intake. And I suspect that some people across the country are just sort of using imipramine or one of the tricyclic antidepressants as soon as they get wind of the fact that this person might have anorexia nervosa.
I think along those lines, the issue of control and manipulation that is so prominent in children with anorexia nervosa, it interferes so significantly in their treatment, is an issue that becomes prominent usually when they begin to regain weight. And in our experience, when they've lost 25% of their body weight and are really in a very starved condition, they've really lost a perception of what appetite is or what hunger is. And they truly are not hungry at that time. And so that maybe the antidepressants are acting on physiological centers to enhance appetite. Once they get up to a more normal body weight, then their loss of appetite is an issue of control, and that's when the struggle begins.
And the very fact of starving oneself gives a kind of high when you're in negative nitrogen balance, I think just adds fuel to the fire and makes things much more difficult to deal with.
We wondered whether it was sort of an opioid, internal opioid high.
Maybe it has something to do with endorphins.
Yeah. I mean, someone's beginning to study that.
Yeah, good. Now, what about school phobia? That's a thing that child psychiatrists are always held accountable for by their general psychiatry colleagues. Frank Rafferty, what's happening with school phobias?
I think we can still better define it as school refusal. And then perhaps clinically we can try to figure out what it is. As you know, some of the youngsters are in fact phobic about school, but many more will have separation anxiety about leaving parents. Interestingly enough, there's a certain amount of traumatic stress syndrome about going to school. I've become convinced that school is probably equally as traumatic to some children as many families are, and that there's an element of traumatic stress for a number of the youngsters in going to school. I've certainly ran across this with youngsters who've been in, say, some of the busing programs, and there have been problems about even extortion of their lunch money when they're at school and things like that, so that one really needs to know very much about what's going on at school as well as what's going on at home. And I think that in general, again, probably most young children respond relatively well to a very determined insistence to go to school and the cooperation of the parents to get them there. I think the most important thing about the school phobia is to make the distinction between the school phobia in the second grader and the school phobia in the 7th, 8th, or 9th grader. I think the latter is much more likely to be concealing a major mental illness and should not be treated in the same kind of
relatively demanding to go to school type way, but should be treated with a full-scale diagnostic study. In the younger child, I think that one has a number of mechanisms to try to get the child to return to school and to support the parent and to discover areas of stress and anxiety that one can treat with supportive psychotherapy, but that will not work in the older child.
Now, if it evolves that the child is suffering from sort of garden variety separation anxiety, what kind of treatment do you recommend?
Well, garden variety separation anxiety is more of the weed variety. And what was it that Elva Posnancy was talking about? The treatment of a relationship. And that, of course, becomes certainly a major problem in treating the child with extreme anxiety as a result of separation, because there's usually something going on with one or both parents that precipitates the separation anxiety in the youngster. And those are definitely cases that one must treat the family simultaneously.
I think Frank's point about the school being a problematic area is an important one. In my experience, one is unlikely to be very successful in the treatment of this school refusal syndrome, even in the younger child, unless the psychiatrist goes to the school and deals with the teacher. One, assesses the situation, but two, supports the teacher in allowing special favors or special programs for this particular child, so that the psychiatrist or child psychiatrist who's involved is not only working with the child and the family, but needs to work with the school if the outcome is going to be successful.
And I think some people would also recommend imipramine in addition to this overall psychotherapeutic approach with kids with separation anxiety.
You know, there are two areas that I fear we haven't got into at all, one being the alcoholism and drug use problem with adolescents. Anybody have anything really new to say about those?
Doesn't seem to be diminishing, certainly.
We're going to try to start using naloxone or something like that with alcohol abusers?
There's a great deal of interlocking of the affective disorders with substance abuse. I think that's a generalization that applies particularly with young people, and maybe in a way that's a little more complex than with adults. I know their general psychiatrists are recognizing that with adults that many an alcoholic may be depressed or have a bipolar illness, and they're doing some very good diagnostic work on that score.
Some of the
Well, the children, it's
epidemiology
difficult.
may be geographically related, because I'm struck with a notion that all these fads develop in California and move east, and that certainly drugs in the school were a major problem in California among at least the kind of suburban school systems that I've been associated with.
Is that where they
10
came
years
from?
ago. But now they're not. Now it's alcohol that's the problem, and the problems are on the East Coast in the schools with drugs. I'm not sure. I mean, this is impressionistic. I don't have the data. But it's not so much a problem on the West Coast. So maybe there is a decline in drug abuse. Maybe the public health efforts to educate adolescents about drug abuse have been effective. Certainly, smoking seems to be a problem that is no longer a major one for adolescents. I mean, we all used to sneak around behind the fence to have a cigarette. I don't think that's going on so much anymore.
I think the epidemiologic studies show that for young women, adolescent women, there's been a tremendous upsurge in the number of young women who are smoking cigarettes.
In
Tobacco,
adolescence.
cigarettes made of tobacco, yeah.
How about the use of marijuana? Do you think, has that stopped in California?
No, it hasn't stopped, but I think it has. There's social pressures, at least in the middle-class suburban schools, not to engage in marijuana smoking, that are almost opposite to the social pressures to engage of 10, 15 years ago.
And the social pressures to engage in alcohol use?
Are there? Yes.
Well, I think the older generation often says to young people, why do you have to use these hideous drugs that are illegal when you could be using our favorite drug, alcohol? And we see certainly a lot of that in clinical work with families. The kids feel under some positive pressure from the parents to switch to alcohol instead of whatever their recreational drug might be. Well, we haven't really had time to touch on a lot of clinical conditions that we really need to cover if our goal were to be complete and thorough, but we don't have time for that, and I think it's time for us to end this little conference that has certainly been very pleasant for me. I want to thank both the American College of Psychiatrists, who got us together, and Dr. Tom Anders from Brown University, and Dr. Frank Rafferty from Healthcare International for joining with me for this discussion this afternoon. Thank you.
You have just heard Recent Advances in Child Psychiatry, a panel discussion in the Update series. Update, a clinical continuum in psychiatry, is an educational service of the American College of Psychiatrists.